Welcome to the module on assessing pain in older adults. While pain complaints are quite common in the older adult population, they're not normal, and there's much that we can do as an interprofessional healthcare team to assess and to treat their pain. Today we're going to discuss the prevalence and impact of pain on the older adult population and learn how to evaluate an older adult's pain concerns. The World Health Organization defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such. So even from the World Health Organization, we're seeing immediately that the definition of pain involves both the sensory inputs as well as the emotional and psychosocial response to them. Reflected in this diagram, we see how we have an initial source or cause of the pain, which leads to that physical symptom that the individual perceives. And then it's modulated by their physical, psychological, and social factors that feed both back up into the pain, but then that pain influences those factors as well. In older adults, the prevalence of any pain complaint is up to 72%. In community-dwelling older adults, 25 to 50% have persistent pain, and up to 80% will have a pain-producing condition, such as osteoarthritis. When we look at the nursing home population, these numbers continue to rise, and 50 to 85% have persistent pain, in which case it's often undertreated or not treated at all, and it's common often with chronic illnesses. Pain co-occurs at multiple sites for many individuals. As you can see in this graph by Patel and others, on the far left in those blue sections, you can see where individuals have only pain at that particular site. And as the bars move to the right, those additional colors indicate that they're experiencing pain at one more site, two or three or more additional sites. We'll use back pain as an example. On the top line of the graph, you could see there in the blue that 12% of individuals with back pain experience pain only in the back, whereas the majority of individuals experience pain at 1, 2, or 3 other sites. There are changes that occur in the nervous system that alter the perception of pain. The decreased density of unmyelinated fibers and decreased intensity of those fibers make people more likely to experience pain at lower thresholds. The brain changes also include decreased volume in the prefrontal cortex and hippocampus, which affects a person's ability to cope with those pain perceptions. But older adults are not less sensitive to pain. That's actually a common myth. They do interpret pain in the context of their overall health and life stage. So some may downplay their experience of pain for fear of it signaling a worse illness. Older adults do perceive their pain as normal or to be expected. They may be less tolerant of pain because of changes in their coping mechanism of their social structures or their other medical illnesses. And again, those coping structures may lead to changes in that perception just in and of themselves. We divide pain into acute pain and chronic pain. Acute pain is really that immediate response that lasts for about 8 to 10 weeks to an external or an internal injury or damage. Its intensity really does correlate to the triggering event or the injury. It usually can be clearly located. You can say my arm hurts or my hip hurts if I broke it. And it's distinctive. It's a warning sign. It's meant to signal, hey, something's wrong here, and we need to look at it. Chronic pain, on the other hand, really becomes a chronic disease of its own right. It's uncoupled from that initial pain-inducing event. The intensity is no longer actually responsive to the pain that's occurring. And chronic pain is no longer a warning or protective signal to the body. It becomes its own therapeutic challenge, and we'll talk a little bit more about that. So for acute pain, that pain response initially, those protective mechanisms allow us to get in, hopefully to control the pain while we evaluate what the underlying cause of the pain is. We treat the pain in that instance to allow for healing and for recovery. If we manage acute pain appropriately, we will decrease the likelihood of developing chronic pain later on. Chronic pain is often multifactorial. This is now uncoupled, as we said, from that initial triggering event. And so it becomes more difficult to manage because we also have to look at the biopsychosocial factors that are playing a role on that individual's perception and coping strategies to manage their pain. It often cannot be completely eliminated, and our goal of this is to control the pain while we maintain or optimize their function. So pain and function are related. As we see again in this graph from Patel and others, as the number of sites of pain increase, as designated by those different colored bars, the inability to walk 3 blocks unassisted continues to go up. So, as you can see, in the 75 to 79 age range, about 10% of those with pain at only one site cannot walk 3 blocks, whereas those with pain at 4 or more sites, up to 60% of those cannot walk that far. Now, this might not seem very useful, but think of how far it is to park your car, to get into the grocery store, to do your shopping, and to get back to your car. 3 blocks really does impact a person's ability. And aside from function, there are many other complications of untreated pain. You might see sleep disturbances, decline in their social or recreational activities, further functional decline and deconditioning, including increasing the risk of falling. Depression, anxiety, and cognitive decline can be related to untreated pain. And malnutrition. Somebody who's in pain often is not able to maintain their nutritional status. So these may look familiar if you've seen the other modules, as these are common geriatric syndromes that affect our older adults. The ability to manage a person's pain is the ethical duty of the healthcare team. And how do we do that? We really should look at pain management as a team sport that involves the entire interdisciplinary team to identify not only the physical cause of pain, but to identify the psychological, emotional, and spiritual complexities that may worsen or trigger other pain complaints. So when we assess pain, we divide pain into 2 different types. We have nociceptive pain and neuropathic pain. When we look at nociceptive pain, that is pain that is occurring to the different tissues in the body. And we divide that into somatic, so the muscles, ligaments, tendons, and bones, and then the visceral, which is the inside parts. When we look at an insult that occurs to the muscles, tendons, or bones, it's often well localized, sharp, stabbing, aching. You know, if you've ever fallen and broken an arm, you can say, it hurts right here. This is also common in osteoarthritis, where you can pinpoint that pain to a specific joint. Visceral pain, or the pain that occurs to the organs, is usually described as sharp or cramping. It could be tearing or squeezing, and oftentimes it's because of the innervation changes, it is difficult for an individual to localize. This is called often referred type of pain. If you've heard about people who've had a heart attack, they might say not that it's hurting in their chest, but that it's hurting up into their jaw or down into their arm. You might also get colicky types of pain, so a bowel obstruction or gallbladder stone. That's that squeezing of the muscles of those tissues as it tries to pass that blockage. And then if you get more of a diffuse type of pain, that might be related to peritonitis or the inflammation of the entire peritoneum. Neuropathic pain, on the other hand, is that pain that occurs when there's damage to the nerves. It could be radicular, which means it's a single or a multiple nerve root. Sciatic pain is an example of a radicular type of pain. It's often described as burning, numbness, shooting, or tingling. And it can occur along those roots, like that radicular type of pain. It can occur more in a stocking or glove distribution that you might see in like a diabetic neuropathy. Or along a nerve root, you might also see pain associated with a herpes zoster infection. When we take a history, it's important for us to get that individual's perception of where their pain is. Pain is often difficult to get because it does rely on that person's self-report. There are no markers that we can see that says, aha, there's where the pain is. That person is able to localize it, tell you where it hurts, tell you what does it feel like. Again, that burning, sharp, stabbing, cramping type of pain. How bad is it? And those pieces will give us information on what type of pain we're dealing with. When we're able to identify relieving or exacerbating factors, and then we also need to assess its impact on mood and function. When we do this, as with many things in our older adult population, we also need to assess how this pain fits in with their goals of care or their preferences for their care. Their biggest worry might be something totally not related to what's causing their pain, and that's important to know as we create a treatment plan for them. Some examples that we can use to determine particularly the severity of pain are shown on this slide. Some of those might be the smiley faces or representations of what the person's face looks like as they're describing their pain, their grimace, for example. They can use a visual analog scale where you actually mark along a line how bad the pain is, from no pain at all to the worst possible pain. We can describe it. We can call it mild, moderate, severe, very severe. And then, of course, that numeric rating scale. So on a scale of 0, where there's no pain, or 10, where it's the worst pain you could ever imagine, where they fit in that mark. So now let's talk about the intersection of chronic pain and chronic illness. That patient self-report is the most reliable assessment of pain. And so many people wonder, what do we do when a person has something like cognitive impairment and can't report their pain? Well, that's actually a myth. Older adults with dementia, even those with advanced dementia, are able to tell you what their pain is now. They may not be able to tell you what their pain was before breakfast or yesterday, but that pain right now, they can share that with you, which again is why it's important for us to have a team, for frequent nursing visits, for the physical therapist to weigh in, for the family members to weigh in and provide additional information. It is important to focus on their function. So an older adult may be reporting some pain to you, and that is definitely necessary, and we need to address that. But taking into account how their function is being affected is also important. We need to assess and optimize their treatment for underlying diseases. Heart failure, cardiac disease, diabetes, those on dialysis, all of these illnesses increase the likelihood of a person having chronic pain complaints, even without another assessment. And then it is also important for us to assess how their treatments may be impacting their pain. Common side effects of medications used to treat cancer, those with end-stage renal disease on dialysis, and even those with heart failure, some of those medications, one of the side effects might be that it increases their risk of having pain. And if we don't look at this full picture, it will be difficult to manage their pain appropriately. In conclusion, pain complaints in the older adult are quite common, and it's important for us to use the entire interprofessional team to create a care plan that optimizes their pain control so that they can continue to live a vibrant and functional life.